Hello and welcome to ACL Wise. My name's Tom Jacobs, and in this episode we are talking to Nick Nicolaou, who is an orthopaedic children's knee consultant up in Sheffield, and we're going to be talking about lots of different topics around specific ACL injuries to children and how it affects them differently to adults, and what we need to be considering in the complex interplay for these children's injuries. So let's crack on. Hello, Nick. Nice to be here with you. We're at the British Orthopaedic Association conference here in Liverpool, which is the first time I've been in Liverpool, and it's fantastic. Really great to be here. Some great conversations that are happening. For the listeners, tell us a little bit about what you do, and in relation to the ACL world specifically, why is ACL injuries important to you?
Okay, so I am a children's orthopaedic surgeon. I'm a bit long in the tooth now. I've been doing this for a fair bit of time, and my subspecialty interest is in the kids' knee. So I treat the whole spectrum of paediatric knee pathology, from congenital to traumatic injuries. And I got to that via a rather roundabout way because I moved to a department. We had a really good team, and the only thing that wasn't really being done was ACL reconstruction because the chap that retired wasn't replaced. So I'm an accidental knee surgeon who's had some fantastic trainers in my early career, as well as a really good team of adult surgeons that have supported me in developing the service. And kids' knee injuries are common, difficult to treat, but with appropriate care, input, multidisciplinary recovery after surgery and injury, you can get kids back to what they love doing. That's satisfying. Gets to see them get back to what they couldn't do before.
Yeah, I know we chatted previously about within orthopaedics, there's been a bit of a shift over the years from thinking about things in very general terms to being a little bit more specific for children. Tell us a bit about how that's shifted in recent years.
Yeah, so it's multifactorial really. It's a shift in the NHS. The size of departments used to be really small, so you'd have let's say one hospital, 4 orthopaedic consultants who would do everything amongst the group of them. Now we see bigger departments because of the way the NHS has changed, which allows people to subspecialise a little bit more. But the field of paediatric knee surgery was always with adult soft tissue knee surgery, and what we're finding is the guy or girl that was the consultant dealing with knee injuries in adults and doing some paediatric orthopaedics, that doesn't exist anymore. It's either one or the other. So that has meant we've seen a shift, and that's allowed this particular field to develop, where you have people with experience of both methods focusing just on children's care.
And why was that shift the case? As in, why couldn't you treat an ACL injury for a child, for example, like you would an adult? Why has there been that kind of niche for surgeons?
Kids are different when they hurt their ACLs. They're almost a different demographic. So they're probably more at risk because of anatomical and other movement factors to start with. Also, their risks of failure are super high, 6 times probably that of what an adult would be. So they are more difficult to rehabilitate. They are still growing, and the techniques that we use in adults aren't directly transferable to children. The data that we see and what guides us into what treatment we should do for adult ACL injury isn't directly applicable to children. So all these things play a role. So they are in some ways getting treatment based on the adult population as opposed to tailored specifically for their age group. And that's changed a lot over the last decade and continues to get better, and we see almost a subspecialty appearing where paediatric knee surgery is carried out by people that focus on that either as part of their practice or as their sole practice, which allows them to focus their energies, their time, their team approach to management to put the kid first and not treat them as a small version of what you are seeing in your general practice.
So instead of it being an afterthought of adult orthopaedics, it's become a bit more of its own subspecialty. And you as a knee surgeon, when you started shifting to doing children's knees, how would you go about an ACL operation in a different way to, say, an adult orthopaedic surgeon might?
So the thing with kids is the techniques vary according to how much growth they have remaining, the aim of which is to minimise growth to stagnance. So because of the growth plates, some of the methods that you would do in an adult, if you do them in children, you will cause deformity and you will cause problems. So graft choice is different in children, not massively, but slightly different. The technique of performing the ACL reconstruction and putting your graft into the knee, as well as the other parts of the procedure, need to be carried out differently. More importantly, the rehabilitation is more of a challenge. I mean, it's a challenge for everyone in terms of engagement, but for kids, keeping them on board and giving them the time they need to build them back up to when they can reintroduce their normal activities is a much different process.
Yeah, and there was that Paterno study, I think in Australia a couple of years ago, that showed that building up kids' strength comparatively on the operative and non-operative limb, getting that to more parity, is much harder to do in children than in adults for some reason. So I think at 7 months there was a lot less children who'd been able to get the leg up to strength of the opposite limb for some reason in rehab.
And sometimes you don't even get back to equal size. So even if you do it and follow them up for 2 years, you can still find differences. And that's the issue and the difficulty that we have.
Yeah. You've been in this sector for many years. What trends have you noticed over time or observations you've made in your knee clinics when you're treating kids with soft tissue injuries of the knee, or observations?
So I suppose the spike I think that we were seeing, I think we're seeing it level off in terms of incidence. And obviously one surgeon in one region can't tell you what's happening nationally. It's just what I call level 7 evidence and non-expert opinion. But we are getting an idea from where data is more robust in other countries that probably we're seeing rates of ACL injury decrease, which I think is because we're getting better at preventing injuries, which is the best way to treat ACLs, is to stop them happening in the first place. So in the UK, we're probably a little bit behind where that data's coming from, particularly in North America. The whole area of kids' knee injuries is in a different place to where we are at the moment, because of how our healthcare system is. But we still see a lot of injuries. It's just we're probably not going to see as many as we did before, is what my own feeling is. That could be wrong.
Yeah,
time will tell.
You mentioned that the statistics are a little bit depressing in children who have an ACL injury. We try our best to help them, a reconstruction or non-operative management in some cases. But regardless of that, there seems to be this very, very high, you said 6 times more likely to re-rupture the ipsilateral, contralateral limb than adults. Have you got any thoughts or musings as to why children are so more at risk of re-injury after they had an ACL?
Yeah, so it's, as in all things, there's a lot of factors that play into this. I think that a kid's ACL injury is very different to late adolescence. So a young child, for them to rupture their cruciate, it's to do with, first of all, the generic things, the way they move. So they're growing, things are constantly changing. They have poor neuromuscular control. So the ability to resist forces across the ligaments could be an issue for them with certain activities. They are neuromuscularly perhaps too focused on single sport specialisation in the UK, so we don't see that generic strengthening of kids doing everything, which also plays a part. They're playing more sports at high level at a younger age, which puts them more at risk. Then surfaces they play on, all these other things that we factor. Then there are anatomical factors. So it's the, for example, the size of the notch in which the ACL sits differs. The way the ligaments are made up, so the genetic composition of the collagen that makes up their ligaments may well be different, which is why there's always a family history. Well, in a third of cases, there will be a family history of ACL rupture. Yeah. So then there's the anatomical factors. And then there's the aspect of injury prevention, secondary injury prevention. So the rehabilitation is harder, it takes longer. And during that process they're growing, and it's a constant changing thing, and I always say to patients, when they have an ACL rupture, if you look at a group of boys, for example, or girls playing football at the age of 9 or 10, they look absolutely awful in terms of what they can and can't do. There's always one gifted individual that could do everything. But then you look at the same boys or girls 3-4 years later, their control is better, because that whole process of neuromuscular development takes time, and it continues way beyond the paediatric age groups.
Yeah. Biomechanics is obviously quite complex. You said there's a lot of moving parts going through their bony development, and children are not all the same. So we chatted a bit before about the torsion and the anteversion of the femur, the tibia, means that some people are perhaps a bit disadvantaged with the risk of developing an ACL. Would you agree with that?
Yes, so alignment issues do predispose to injury, and in kids alignment changes, and there is torsion, so twist on the femur and the tibia. There is varus and valgus, so knock knee or bow legs, and then there is the angles at which the joints at the knee set, so the slope of the tibia. So in some people it can be sloped backwards. We know that if your slope goes backwards, you're more likely to have, in the adult age group, failure of your ACL reconstruction.
And the theory behind that is that the tibia there is more likely to slide forward on the femur.
It's translational forces. Yeah. That's why also lax patients, they hyperextend as well. So that's not an anatomical feature of the bones, but that also predisposes that hyperextension to ACL injury as well.
Inclusive the rest, isn't it?
And probably of all of those, it's the knock knee, the valgus, that causes more of an issue, but we don't quite have that link between what we call static, so bony valgus, and dynamic valgus, the movement patterns. That's more complex because it involves control and strength and various other factors. And that interplay is quite complex.
So just to explain that for our listeners then, bony valgus, am I right in saying that the angle, the lateral angle, if you like, of the tibia will put someone either with the knee straight or the knee will drop in a bit? And then dynamic valgus, we're talking about something else.
It's during movement. So let's say, for example, you've got one of your patients in clinic and you get them to do a single leg squat or a hop and a squat. You see that knee wobble a little bit and then come across to the middle limb, because the control of the limb is quite poor, which is partly strength, but other things as well. It's control return. So that will predispose, if you're doing a pivoting or cutting movement or a pitch, whatever sport it is you're doing, to put the forces through and risk down or cruciate.
Yeah. So some of those are modifiable and some are perhaps less modifiable, arguably. Yeah. In terms of management of ACLs, a lot of people who don't know this area very well will see things coming up on social media or in paper discussions around, do we manage people operatively for an ACL reconstruction, or do we manage them conservatively? And I know that's been a debate in the adult sector for a long time. As a kid's knee surgeon, can you help explain a bit to the listeners, why is it that the rationale would be we should probably operate on an ACL rupture in a child?
So the concern with children is always ongoing instability and accumulating damage within the knee. And we know that in children, the chances of getting irreparable or significant injuries to, for example, the meniscus is much higher than it is in adults. So and that comes from the severity of the instability. And obviously meniscal injuries you can treat surgically, but you can't always guarantee a good outcome from them. And for, in particular, lateral meniscus, if you lose some of your lateral meniscus because someone's taken it out because it's not healed after repair or it just wasn't repairable, we can argue that most tears you can repair in children. The point loading that you're going to get is going to cause the joint surface to fail in the long term. So although ACL reconstruction doesn't prevent osteoarthritis later down the line, what it does do is it prevents meniscal injury, which we know is linked to more strongly to osteoarthritis.
So what you're referencing there is that after an ACL injury, whether they're managed conservatively or operatively, that about 40% will get osteoarthritis within 15 years or so, symptomatic, significant osteoarthritis. But what you're talking about now is the meniscal damage. So the rationale for a surgeon is, if I don't want this child to go on to have significant meniscal injuries, I'll be better positioned to manage them operatively and put a graft in.
Yeah, and that's in particular, it depends where you are in the world and what resources you have.
Right.
So in the US, your data from the Pluto group published this year, 99% of ACL injuries that are diagnosed are treated with surgery. But that's to do with their healthcare system, their culture, and the way they work as a nation. In the UK, there is probably a similar figure, although we don't know exactly because we don't know how many ACL injuries happen in the UK every year.
Got the exact
No data that's accurate. So conservative or non-operative management plays a smaller role, and the actual data that we have on success of non-operative management is limited to small case series from countries where the healthcare system is very different to what we have here in the UK.
Right. Okay. So I know there's interesting conservative management trials going on at the moment, and like you said, there's not a lot of concrete empirical evidence. I know Australia are working on a bracing protocol to trial in the UK and a few other countries as well. And you mentioned about Oslo and what they're doing over there. But in terms of current best practice, what you're saying then is that the overwhelming majority of kids who rupture their ACL will probably end up with a reconstruction of some form.
Yes, and they should always have options discussed with them. So if someone comes to me to clinic, and any surgeon that does any form of operation, you always discuss options to the children and their parents. So the options for an ACL rupture are non-operative, and the risks, you will explain what those are. And the risks will be ongoing instability, which is very common in kids after an ACL rupture, cumulative damage to the knee. Those are the two main things. Then with operative surgery, you have other sets of risks, which you would discuss. Now, when you give that choice to patients, it's no different to when you see someone in your clinic, you're working out what you're going to do to get them better after whatever injury. You can always push people to one direction or the other and advise them what you think is best, but overwhelmingly, even though ACL, people know that the rehabilitation is going to be long and hard and there are risks for surgery, the kids and the parents always go for the surgery, more or less. It's almost invariable. Very few people will say, well, let's give non-operative management a try. But you shouldn't treat an ACL injury non-operatively if there's meniscal damage, because you can't guarantee that it will heal. And if it's a significant tear at the time, you would go and repair the meniscus. Because an unstable knee, re-tears and failure to heal are common, it's best to do the ACL reconstruction at the same time to fix the meniscus.
So for non-specialists in this field then, what would constitute a significant meniscal tear or a less significant meniscal tear? Because the menisci have the capacity to heal in some cases.
Yeah, they don't heal well if the knee is unstable, so that's the problem. And sometimes you'll perform an ACL reconstruction and you'll see evidence of a little tear that's visible on the MRI scan, that was visible on the MRI scan that has healed. That's actually quite uncommon. What you often see is tears that weren't there before. So were they missed by the first MRI, or did they happen after the MRI was done while the child was waiting for surgery? Because they accumulate the damage really quickly in the knee. And it's worse in the kids who aren't diagnosed. So if you diagnosed on day one with your ACL rupture, you have your MRI scan really quickly, you see your physiotherapist really quickly, they start your treatment, they brace as appropriate, they rehabilitate you. You might be someone that will manage without an ACL. So trying to do that in the UK is impossible with our healthcare system.
Yeah, so we've got real challenges then in terms of early management. So your feeling is then if the early management in a perfect world was there, and like what they're doing in Oslo, where people get seen very quickly for exercise, bring down the effusion, and get them strengthening and conditioning, you feel like that might have an impact on outcome?
Yeah, possibly. I think it's the quicker you get these things sorted, the better it is for the patient. But if we're talking about non-operative management, not all of them will manage without their ACL. So even if you start early, get them strong, rehabilitate them, brace them for contact sport. That's the other thing, is the Norwegian group, if I remember rightly, they brace the children post-ACL injury once they were ready for sport, for contact sport.
I can't remember if they do or not, but I think a hinge knee brace possibly. it's also this thing about is there other ligament injury that coexists at the same time, and I certainly think collateral ligament injuries would be braced for, but yeah, it's an interesting point about the timing of intervention, timing of rehabilitation post injury. The question that I ask everybody, Nick, on the podcast is, if there was one thing that you would like to see change in the ACL space within the UK. Obviously, we're both here in the UK, and we've talked about other countries that are doing well. What would you like to see change in the coming years within this space for the demographics we're talking about?
So just one thing.
I think I'll try and pin you down.
All right, one thing. I would like to see a national injury prevention program for children that's implemented in every school, every club.
Okay.
I would like to be put out of business by preventing the injuries from happening.
Yeah. So you think upstream is the best option we have at the minute? To the best treatment for ACL is to try and stop them happening.
Yeah, that's the best strategy, and we know that it works. We just need to implement it, and there we need stakeholders to engage to facilitate that from happening.
Yeah. And the detractors from that would say that you're always going to get some ACL injuries, right? And we acknowledge that point. But your feeling is that a portion of them we can stop happening.
I think that we know from data from various countries on what it works. What we don't really know, because we probably need to get to where we need to go, we need to implement some proper trials that look at community-based injury prevention, and we need to know what age we implement it, what age we target, what the program will be, how we record and assess the outcomes of the intervention so that we can improve and roll it out everywhere.
I think you also point about effectiveness. I think only down to the age of 14 we've proven effectiveness. There's also this bit about that younger age group, which is a smaller number of the ACL ruptures, but
indirectly we do know that if we don't know about injury, but we know neuromuscular function is better if you intervene at a very young age, but we don't know about injury prevention at a very young age. So I think the younger you go, the better it's going to be, but we can't prove it just yet.
Yeah. Well, thanks very much for joining us, Nick, and giving up your time. I know you're a busy man, you've got lots on the go, so I think the listeners will be really appreciative.
My pleasure.
And we'll try and get you back at some point in the future. Thanks for watching this episode of ACL Wise. Don't forget to like and subscribe, and look out for the next episode coming soon.